everybody. I'm talking to you here from the AACR conference in New Orleans this year. My name is Siegfried Hauch. I'm coming from QIAGEN Hannover in Langenhagen in Germany. What I would like to do today is to introduce you to Professor Dr. Sabine Casimir-Bauer from the University Clinic for Gynecology and Obstetrics in Essen, who is presenting a wonderful piece of work in terms of the molecular characterization of circulating tumor cells and their predictive meaning. So, Professor Casimir-Bauer, a real good piece of work done here in our long relationship now in collaboration for over 10 years. We have now these fantastic results here. Could you please be so kind and explain us a little bit what it's about?
So we are working on ovarian cancer, and the main problem in ovarian cancer is the resistance to platinum-based chemotherapy. And the problem is that this resistance can only be assessed retrospectively in the follow-up of post-chemotherapy. And so it's very important to detect a marker which indicates platinum resistance. And so my former student, Jan Dominic Kuhlmann, worked in that field. And what he did, he analyzed circulating tumor cells, and he found out that ERCC1 positive circulating tumor cells, and ERCC1 is a marker for resistance, that the presence of these cells right before the onset of chemotherapy is responsible for a worse progression-free survival, overall survival, and clinical platinum resistance. And now our main question was whether this negative prognostic impact was related to the presence or the persistence of these cells after chemotherapy. And so we were able to analyze 65 patients before and after chemotherapy, and we were looking for ERCC1 positive cells. And the main result is that circulating tumor cells carrying this marker after chemotherapy and persisting cells are related to this worse outcome. And what is also one main finding is that those patients where we never detect circulating tumor cells, that they have a better outcome than all the other patients, also those patients where cells are eliminated after chemotherapy. And so we can clearly demonstrate that these resistant circulating tumor cells are really responsible for this worse outcome. And this might be a monitoring tool in the future to identify patients who might not respond to platinum-based chemotherapy.
So circulating tumor cells not to be taken as a prognostic marker only, but also as a predictive marker.
Yes.
Do you have more examples for that? Is that the first results you have in prediction capacity of circulating tumor cells, or is there more to await for?
No, I think despite the prognostic impact of CTC counts, it's really urgently needed to characterize these cells. We see the same results in breast cancer. For instance, if we have patients with locally advanced breast cancer and monitor them before and after chemotherapy, we clearly can identify a certain population of cells, for instance, resistant cells like in ovarian cancer, but also stem cell-like cells. And these are the cells which are left after combination therapies, chemotherapy, antibody-based therapy. And so we also see in metastatic breast cancer that in case we characterize these cells, that for instance HER2-positive cells really can be eliminated after HER2-targeted therapy. And then later on, when these patients progress, other kinds of cells come up, like HER3-positive cells or resistant cells.
So that means, in clear words, so over the counting, which has a certain prognostic meaning, of course, no doubt about that, the add-on information we can get using the expression profiling in circulating tumor cells is leading to predictive information, which could be useful in guiding therapies forward.
Yes, I would agree, because I think it might be a nice combination, especially for the medical doctors, to have the CTC counts on the one hand, and then later on characterize those cells which are left after therapy.
So you were using the ADNET test ovarian cancer here for this study. What is your that is one thing, CTCs and the molecular characterization using that test. But what is your opinion about other technologies that are now mentioned always in the context of liquid biopsy, like NGS, for instance?
Well, NGS of course might be a tool to go into more detail, but I think on the other hand we have the circulating DNA, and this circulating DNA might be especially interesting for tumors where which are diagnosed according to mutation, like for instance lung cancer. So patients are diagnosed with lung cancer, the tumor is characterized, and then these patients are treated according to their mutations. And so circulating DNA would be a nice tool to monitor these patients during follow-up of the disease. Next generation sequencing is of course one of the upcoming modern methods, but is of course a matter of price, and the evaluation of data or results is very important, so that you have good bioinformatics which really guide you into the right direction.
I mean, that's where we have to come to, right? We have to combine actually the whole liquid biopsy field, if it is NGS, probably even exosomes, and the information of the expression profiles, and put it into a bioinformatics tool that gives the medical doctor then the information what really to do with the patient.
Yes.
Because my opinion is that the medical doctors, for them, this whole amount of scientific information we have there is by far too much, right?
It's much for the medical doctors, and when we are coming back from conferences we even have more ideas or even indicate more methods, and so it's also they have to treat the patients according to guidelines, and they cannot change according to new methods or new results. So we have to prepare little clinical studies to, for instance, have a proof of principle and then go into detail or bigger studies to guide patients accordingly and treat them accordingly to these markers we find.
Right, the interventional trial is still missing. We have to say that, I have to admit that. Nevertheless, what would you say from your knowledge about your collaboration also with the medical oncologists in the University of Essen? If we have such a result, coming back to this poster now, if you have such a result showing a clear predictive information that first-line therapy is not working in ovarian cancer patients, but another therapeutic regimen could probably work, what do the doctors say to you? What has to be done to really bring it into the clinical practice?
Well, what has to be done is really to conduct a pilot study. For instance, when we talk of ovarian cancer patients, I mean, the problem is that there are not so many therapeutic options like in breast cancer, where you have a variety of different therapies. So for ovarian cancer, we could conduct a little study. So after 3 courses of therapy, detect the CTCs, characterize them, and in case these patients are positive, make a 2-arm study. One patient group continues with platinum-based chemotherapy, and the other group has to get another drug. But then the question is what kind of drug to give.
Right.
And it cannot only be done in a single hospital. We have to get together with other clinics involved in ovarian cancer and conduct a study together to have a proof of principle.
Right. I think that clearly would be the next step, what we should do with these results already here, these fantastic results actually already here. But I assume that you would not stop at this point, right? So what are your plans for the future?
Well, we have another poster which will be presented tomorrow by one of my PhD students, and this is the analysis of bone marrow cells, so also before and after therapy. And what we can clearly demonstrate that stem cell-like cells are responsible for worse outcome. So we do not only have the platinum resistance, we have also the stem cell-like cells, and a third column, let me say, is the immune system. We also can demonstrate, and these are data which we presented last year here during the AACR, that you have an infiltration of immune cells in the primary tumor, and they somehow direct tumor cell dissemination. So this is more or less a potpourri of factors we have to look at, and so the combination of all will perhaps help us in guiding therapy or identify patients who might benefit from additional therapeutic regimens.
Fantastic. A little bit forward-looking in the future again. This morning I had a very nice discussion in the hotel breakfast room with a guy that was asking me again the question, what about CTCs in screening? I immediately said, no, don't do it, not sensitive enough. But then he said to me, listen, if we would have in the killer cancers like the ovarian cancer, if we would have only 25% sensitivity before surgery, this would be so much helpful, assuming that the specificity would be also there. your experience with that test, how would you say the specificity is already there, or is there more to do?
Well, the specificity is there. Of course, we are now moving into multi-marker analysis, into real-time PCR to be more precise and to be more specific. But of course, in the clinic, when you're working together with patients, if you offer a method, you also, of course, have to offer a therapy. And so, of course, many patients are willing to have their blood identified or their bone marrow, but of course, it's also a matter of money. So you really have to indicate these different time points.
Okay, I think this was all my questions I had today. I again thank you very much for this great piece of work, and also to your co-workers Isam Chabuti, Jan Dominik Kuhlmann, Pauline Wimberger, and Rainer Kimmich, who is leading the department. Thank you for this great piece of work. I hope that our collaboration will be fruitful also in future, and I would say have fun on the AACR.
Thank you.